Cholera is a historically well-known disease, but it has reemerged as a severe, modern global health crisis, escalating with unexpected aggression. This map shows the massive geographical distribution of cholera cases reported worldwide between 2022 and 2023. The spread breaks from historical models. We are seeing simultaneous strikes across traditionally endemic regions, as well as countries that previously had no active transmission. Looking at this surveillance report, the most alarming metric is the case fatality rate. It is significantly higher than in previous years, driving a toll of up to 143,000 annual deaths. Traditional epidemiological methods, like reactive contact tracing, are failing to contain this wider, deadlier footprint. Accelerated climate change, porous cross-border movement, and highly adaptable environmental reservoirs have allowed the bacteria to outpace conventional tracking. Containing the disease now requires a transition to regional, real-time pathogen genomic surveillance. In this system, Genomics operates as an active intervention engine, moving simultaneously across two distinct fronts. The first is the macro front. Health agencies track the transmission network by identifying specific Vibrio cholerae lineages as they move across international borders to locate their origin. The second is the microfront. Researchers use that exact same genetic data to engineer, test, and validate the safety of next-generation single-dose vaccines. To manage the macro tracking problem, researchers established the Cholera Genomic Surveillance Consortium in Africa, known as CholGen. This map highlights the specific participating nations spearheading this multi-country analysis, which includes Zambia, Malawi, Mozambique, and the Democratic Republic of Congo. CholGen built this network by leveraging the local DNA sequencing capacity that these countries originally developed during the COVID-19 pandemic. The Terra Bioinformatics pipeline assembles raw sequence data from clinical isolates into a continuous genomic strand. The system then sorts these genomes to confirm specific pathogenic serogroups, specifically O1 and O139. A critical screening step scans those serogroups for distinct toxin and virulence genes, like ctxA and tcpA. Finally, identifying single nucleotide polymorphisms allow scientists to trace exact bacterial lineages. Through this pipeline, a simple clinical swab is converted into a high-resolution, actionable map of how the pathogen is evolving and spreading. This level of genetic fingerprinting allows epidemiologists to separate complex, high-density urban transmission signatures from isolated rural reservoir sources. Finding a rural signature directs targeted water sanitation efforts to the specific contaminated source. An urban signature dictates immediate quarantine and containment protocols. This presentation slide reveals the second major output of the CholGen pipeline, mapping region-specific antimicrobial resistance, or AMR, profiles. The tracking has identified emerging threats, including localized bacterial resistance to standard treatments like tetracycline and trimethoprim sulfamethoxazole. Knowing exactly which multi-drug resistant strains are present allows health officials to dynamically adjust clinical treatment guidelines in real time, preventing ineffective drug administration. When cross-border collaborations share this resistance and lineage data through unified agreements, the entire region can anticipate incoming outbreaks before the first patient arrives. Macroscopic genomic surveillance provides the necessary intelligence to deploy interventions precisely where they will work. However, accurate tracking loses its value if the medical countermeasures deployed upon arrival are outdated. Existing oral cholera vaccines carry distinct limitations. They rely on inactivated bacteria and require multiple doses spaced out over time to achieve full immunity. These multi-dose, inactivated vaccines suffer from longer efficacy in young children, which is the demographic most vulnerable to severe dehydration and death. Furthermore, genomic surveillance frequently reveals antigenic variations in the circulating strains. As the bacteria mutates, the older vaccines become less effective. Outbreaks require a fast-acting, single-dose vaccine that is derived directly from the strains currently circulating in the population. PanChol is a newly engineered, single-dose, live-attenuated oral cholera vaccine developed to meet this exact requirement. It is derived directly from a weakened version of the specific Vibrio cholerae strain responsible for the majority of the current global cases. Live attenuated vaccines carry a specific biological risk. The bacteria could potentially mutate back to a toxic state inside the patient's intestine. To test for this safety parameter and determine the appropriate dose, researchers ran a phase 1 clinical trial across 57 participants. This chart graphs pan-chol shedding, which is the replication of the vaccine in the intestine, acting as a marker for immune activation. 2 weeks after vaccination, participants demonstrated a 100% strong immune response to the antigens. Genomics played the critical role in validating these results. Scientists transitioned from tracking population spread to verifying the molecular safety of the vaccine post-administration. Researchers isolated the pan-chol strains directly from the vaccinated participants' stool samples and performed complete whole genome sequencing on them. The sequencing confirmed absolute genomic stability. The vaccine safely replicated inside the body without regaining its toxicity. By confirming its structural integrity at the molecular level, genomic sequencing proved pan-chol is a safe, clinically viable intervention ready for the field. Public health surveillance and vaccine engineering operate as a continuous, interdependent feedback loop. First, surveillance networks like CholGen identified dominant strains and resistance profiles, feeding that genetic blueprint directly to vaccine developers. Second, engineers deploy targeted therapies like pan-chol. The network continuously monitors field efficacy and stability in real time. This feedback loop is entering active use. Additional Phase 1 pan-chol trials will begin in Lusaka, Zambia. Deploying in this specific endemic African region is a targeted decision dictated entirely by the severe outbreak data tracked by the CholGen network. Integrating this complete sequence-to-solution pipeline directly into affected endemic regions allows public health officials to outpace these highly evasive pathogens. By reading and manipulating the pathogen's source code, modern epidemiology moves from reacting to outbreaks to preemptively engineering their end.